morning, everyone, and again, welcome to our annual Cardiovascular Nurse Technology Symposium, now in its 19th year. And welcome to the Mount Sinai family, as well as our regular attendees and registrants from south of Jersey and different hospitals in the tri-state area. I will be discussing to you today the evolving DES strategy, the use of biodegradable polymer versus bioabsorbable scaffold. The introduction of DES has broadened the use of percutaneous coronary angioplasty in treatment of obstructive CAD. However, there is a substantial delay in wound healing because of the presence of a very potent anti-proliferative drug, and as well as in the end, when the drug is eluted, there is a presence of a metallic stent that further increases inflammation and delayed wound healing. I have nothing to disclose. The timing and mechanism of drug-eluting stent thrombosis could be early, within the first 30 days of implantation. It could be late, 1 to 12 months, and even very late, over 12 months. The mechanisms are multifactorial, and it is believed that the hypercoagulable state, which we find in patients presenting with acute coronary syndrome or patients in ST elevation MI, and plus a stent implantation, a suboptimal result results in the first early stent thrombosis in the first 30 days. Delayed healing and covered struts are more major factors in the very late stent thrombosis. The first generation drug-eluting stent was not ideal for healing because of the following: the thick struts, thick durable coating, high polymer drug dose, and high polymer load. A study done by Renu Vermani, published in 2014, had looked into the DES failure, and it's clear that the following histologic studies pointed out to the presence of, or rather ongoing, neo-intimal hyperplasia beyond stent implantation. The lower, right lower, where's this? Is neo-intimal atherosclerosis characterized by lipid-laden foamy macrophages that they find that are increasing in frequency and earlier in its occurrence in patients that have received DES compared to BES implantation. Event rates persist beyond 1 year with current permanent polymer DES with an annual accrual event of about 2%. This is the Resolute stents compared with Science stents. What is the future of PCI? Let's look back in our history. The introduction of plain old balloon angioplasty by Andreas Grünzig in 1977 focused on getting the artery open. But then we are faced with elastic recoil and abrupt closure. BMS stents came into being, focusing on keeping the artery open by providing scaffolds. But then we found that in doing so, we are faced with 20 to 40% restenosis rate. Then drug-eluting stent was introduced in early 2000. We brought down the restenosis rate to single digits. But now we are faced with late and very late stent thrombosis. Now we want to optimize healing. PCI continues to evolve, and with the improvement of platform design and acute performance to lower the rates of stent thrombosis and target lesion revascularization, to reduce the need for dual antiplatelet therapy, and reduce the risk of neo-atherosclerosis. The Synergy stent design. It uses platinum chromium, which is a dense metal, twice as dense as in comparison to cobalt chromium. It is radio opaque so that it has increased visibility. It provides strong radial strength and prevents recoil. Uses the drug everolimus, and it's in the abluminal surface of the stent. And it's a 3-month drug release, and the polymer is gone by 4 months. How may abluminally coated absorbable polymer DES be optimal for healing? There is freedom from long-term polymer exposure once the coating is absorbed. There is an uncoated surface luminal side to promote cell coverage and adhesion. And of course, the targeted drug delivery reduces risk of restenosis and inflammation. This is the comparison of abluminal and conformal polymer. The y-axis represents the percent endothelial cell coverage of over 20 days, and the different stent you could see in the purple graph is abluminal bioabsorbable, which attained the most comparable to conformal coating. Sorry. The time course of polymer bioabsorption, these are all the bioabsorbable technologies that are available. With synergy, the drug is released in 3 months, followed by the absorption of the bioabsorbable polymer in 4 months. Struts and coating thickness compared. The durable polymer of Science, Promise, and Resolute, you could look at the strut thickness at the bottom, comparable to what we have on Synergy. Synergy, in terms of thickness, has 7 to 4 microns compared to a thick Science. And then you have the polymer, thickness distribution of 4 microns, and it's coated abluminally. Now, this is another comparison, the top being the bioabsorbable vascular scaffold. The middle is biometrics and synergy at the bottom. This is a immunofluorescence staining. You could see that there is decreased platelet adhesions and promotion of endothelial cell function on the thinnest stent synergy. The stent feature designed for optimal healing, the abluminal coating, the bioabsorbable coating, drug-eluting, strut thickness, all are advantageous for healing, decreases inflammation, stenosis, injury, platelet adhesion, faster strut coverage, and faster endothelial cell function. Stent synergy was reported the lowest rate of stents in the real world. We learned from the Swedish registry. They have studied about over 80,000 patients in a period of 9 years from 2007 to 2015, and found that synergy at 1 year in the real world has lowest stent thrombosis. Now, the etiology of very late events with metallic stents beyond 1 year are the following. Dr. Sharma had already alluded to in his previous slides. The uncovered stents, the impaired pulsatility and vasomotion, chronic inflammation due to the presence of foreign body, positive remodeling with those stent struts maloppositions. Then this could be alleviated by the introduction of bioresorbable scaffold. Why is there a need for bioresorbable scaffold? Because we only need the vessel scaffolding transiently. We have a vision to improve long-term outcomes by leaving no scaffold behind. And there are the potential benefits that was already discussed previously. We want to restore the vessel to its more natural state, eliminate chronic sources of vessel inflammation. Excuse me. Hello. Can we play the Rescue Me? I think she comes next. Okay, thank you. Phil, thank you. So, continuing. To eliminate the source of vessel irritation, the vessel will remain free for future treatment, reduce the need for prolonged DAP therapy, allows the use in non-invasive imaging, and overall improve patient quality of life. Now, we have the bioabsorbable vascular scaffolds that are available, but for today, we're going to discuss the absorbable vascular device. It is still undergoing clinical trials in the United States. As Dr. Sharma had mentioned, it is near its FDA approval within the next weeks or so. But it's available worldwide in several countries in Europe, Japan, China, and India. It has been implanted in over 150,000 patients, and 30,000 patients have been studied. This is the product design. It has uses everolimus drug matrix coating with 1:1 controlled drug release, similar to that of the Science metallic stent. It has a polylactic backbone with semi-crystalline circumferential sinusoid, and there is a platinum marker in each of the ring because it's a very thick stent for visibility. Now, the phases of functionality. As promised, just like the drug-eluting stent, it provides revascularization by offering radial support in the first 3 months, and of course, the drug to prevent neointimal hyperplasia. Then there is restoration, a gradual decrease in mechanical support to allow the vessel to restore its natural activity at around the 6-month period, and then complete reabsorption in 24 months to allow the vessel to return to its natural anatomy. Now, someone asked, what happens to the polymer when they disappear? The polymer undergo a process of hydrolysis. As soon as the stent is implanted, it absorbs water in the surrounding cell tissue, and progressively there is hydrolysis that randomly happens to the chains, so that when the ties are broken, the device loses its radial support gradually and becomes hydrophilic, which they get absorbed by the body, and then undergo the process of phagocytosis, enters the Krebs cycle, and then eventually will be turned into carbon dioxide and water. Now, this has been alluded to, the ABSORB trial. It is a large-scale randomized trial treatment of non-complex obstructive coronary disease using ever-eluting bioresorbable vascular scaffold compared with Science Stent, the best in its class, cobalt chromium stent. Now, this is the study design. They enrolled over 2,000 patients, 2-to-1 ratio in the BVS arm and DAS Science Stent. They have a result of 60 months. Primary endpoint, target lesion failure, cardiac death, myocardial infarction, and ischemia-driven target lesion revascularization. They have randomized 2,008 patients with intent to treat. The absorbed arm, there's 99.2% complete, and the Science 98.7%. Some patients were lost to follow-up. 6 withdrew the consent in the absorbed arm, and 6 lost to follow-up in the Science arm, and 3 withdrew consent on the Science arm. And you have seen this slide before, comparing the metallic drug-eluting stent. You see the struts with the arrows. With the biovascular scaffold, you see a very smooth lumen, and which now they refer to as the golden tube. Now, they are out with a 5-year events rate in patients treated with BVS and metallic stents in comparison. The red is the absorb, which has an 11% MACE, and Science stents of 14.3. This is a serial angiography on top, with the white arrows pointing to where the scaffold was implanted, followed by a serial OCT with the respective side branch landmark. And in the IVUS, you see clearly there is a clear plaque decreased in quantitative studies. Imaging studies with OCT, NIRS, and IVUS will be discussed by the next speaker, our research scientist, Yulia. Now there's this release, a recent paper the result of which was released early 2016. A scaffold thrombosis they found that there's higher degree of scaffold thrombosis after BVS. This is 26 studies with over 10,000 patients, systematic review, and some meta-analysis. They found that the incidence is greater in patients that are presenting with ST elevation MI, which we're not surprised because we know that this, when they present as acute coronary syndrome and ruled in, we know that they're in their hypercoagulable state, and sometimes malopposition of stent is there and undersizing, and all of those. So now the consensus from the industry as well as the medical expert has come into a implantation strategy to predilate, to better size the vessel, and then post-dilation is recommended. Now, who are the ideal candidate for the absorbed BVS? Proximal lesions, vessel size within 3 to 3.7 millimeter, lesions lengths of 30 to 40, patients of younger age, less than 60, acute coronary syndrome patient, and drug-eluting stent ISR. IVUS and OCT is highly recommended in the first cases, then in complex cases. Let me leave you with a commentary from one of the top-rated interventionalists, that he says dissolvable stent may be the future game changer for the way we treat CAD in the United States if cautious optimism is proven to show clinical benefits. The stent is designed to open the heart vessels, but eventually will disappear with no signs of remnants of previous angioplasty. Thank you.